study, we wanted to get an idea of whether they could participate. But we did do a water swallowing test where those patients who had the mild to moderate dysphagia actually improved in their timing of their water swallowing test. However, the ones who had a more severe dysphagia didn't show the same improvements. So you can see here the 3 patients who had a more mild to moderate dysphagia. The orange bar is the time of the assessment. So we can see improvement in the patients, in the blue and red patients, and then the rate of decline of that green patient slowed down. And what the patients reported about the therapy is that the vast majority were saying that they were just happy to be trying something that might be helpful, and that they felt like they were taking control of the disease a little bit more and doing what they could. But then we also had those who were kind of the opposite and were saying, you know what, my life is miserable enough, basically. This is the last thing I want to be doing is sitting in a room with you for an hour, swallowing, looking at a screen. And I mean, both are very valid opinions, but, you know, it's good to keep investigating potential options for those in that first group. So as we saw some potential improvements after that training and there were no adverse effects, we started a larger study which recruited 24 patients with MND. This was between Auckland, Christchurch and New York. And from these 24 patients, 19 completed the protocol. So we were more specific with who we recruited to this study because we didn't see the same effects for those with the more severe dysphagia in the pilot study. So we recruited those who had self-reported dysphagia. So we did that by giving them a swallowing screening tool that asks 10 questions. And anyone who scored greater than 3 demonstrated sufficient signs that they had a swallowing impairment. And we also made sure that oral intake was their primary source of nutrition. So for patients who were primarily peg-fed, they weren't included in this study. Because we had reports from patients that the 4-week treatment protocol was quite intensive and a bit much for a lot of them, we reduced that to 2 weeks to see if we could have any improvements with just 2 weeks. And it was a ABA type therapy program, which means that there were 4 assessments and they were each 2 weeks apart. So between assessments 1 and 2, we didn't see the participants. And this was to get a good idea of what changes we might expect to see over a 2-week period, if any, in terms of their swallowing. And then we started the treatment and did 2 weeks of the daily treatment using the software that I spoke about before, that Biscuit software, where patients were sitting for an hour per day, 5 days a week for the 2 weeks, and aiming to swallow so that their swallow landed in that green box. After that, we had another 2 weeks of no contact with the patients, just to get an idea of whether, once we stop the treatment, if we did see any effects, are they going to hang around for a longer term? Of course, 2 weeks is not much of a longer term, but still, that's the short part that we're playing with at the moment. So for this study, we used a lot more assessments. So we had a video fluoroscopic swallowing study, which is an X-ray. We used ultrasound as well as quality of life questionnaires, and those 2 bedside assessments. So the test of masticating and swallowing solids and timed water swallow test, as well as pharyngeal manometry. So I'll go into those a little bit more. So a video fluoroscopic swallowing study is an X-ray of swallowing. So during this, we give patients food and drink that has barium in it, so we can see where it's going during swallowing. I'll play a quick video of what one will look like. So just to orient you, we have the mouth at the front, we've got the spine at the back. This is a bone that I'm going to talk about again. That's the hyoid bone that moves when we swallow. And we've got that little piece of cartilage that I spoke about, the epiglottis, which flicks down and covers up the airway when we swallow. So you'll see in this video that this person is having some pureed fruit. So that dark colour is the fruit and it goes down, and this one went where we would like it to go, down through the esophagus at the back, just there. So from this video fluoroscopic swallowing study, we can get a lot of information about how well different structures are moving during swallowing, and it can also tell us more about whether the food or drink is going the wrong way down to the lungs, whether someone's aspirating is what we call that, or whether it's going towards the stomach through the esophagus. And then it can also tell us a lot about timing of swallowing as well, whether the structures are moving when they should be in regards to where that food is in the throat. The next assessment that we tried to use is called pharyngeal manometry. So this is a small catheter that we place through the nose, and it goes into the throat to measure the pressures in the throat. Unfortunately, none of our patients with MND tolerated this assessment, potentially due to the increased reflexes that people have when their upper motor neurons are damaged. So the gag reflex was quite strong and we couldn't, unfortunately, place the catheter. We also used ultrasound, which I'm not going to go into too much because that's not something we use quite at all at the moment in clinical practice as speech therapists. But again, it can give us a little bit more information about that hyoid bone that I spoke about. We can see the shadow here. So just to orient anyone who is interested, you get the skin at the top of the image. This shadow here is the hyoid bone. We've got the geniohyoid muscle running between the hyoid bone here and the mandible here. So when someone swallows, we can see that hyoid bone move forward towards the mandible. In the other picture, we're looking at the muscles of swallowing, the ones that we are measuring with that EMG under the chin here. So we've got the skin at the top again, we've got the anterior bellies of the digastric muscles on the left and right, and then the mylohyoid muscles running around and the geniohyoid muscle in the middle here. So all very important swallowing muscles, and we can use ultrasound to non-invasively measure the size of those muscles. And then I also mentioned the more clinical assessments that we used. So we have the timed water swallow test, where people are asked to drink 150 mils of water as quickly as they can, and then the test of masticating and swallowing solids, where we'll give people a salada cracker and ask them to eat that as quickly as they can. And so we're looking at the time it takes them to complete the assessments, the number of bites for the cracker, and then the number of swallows for both the water and cracker to complete the full biscuit or glass of water. We also use the swallowing quality of life, which is a self-reported assessment that asks questions about swallowing itself, as well as how quality of life is impacted by dysphagia. So in terms of participants, as I said, we had 19 participants that completed the study, quite even range of males to females with an average age of 66. So we recruited people with both the ALS and PLS forms of MND, and we had people with both spinal and bulbar onsets. Again, pretty similar numbers of both spinal and bulbar onsets, but of course everyone had swallowing impairment of some degree. So we had 7 people who were taking medications for this, for the MND, and quite a range of time since diagnosis as well. In terms of the results that we saw, so first of all, the swallowing quality of life scale looked at the total symptoms score, where we saw a significant improvement in scores between the baseline period and the treatment assessment. In terms of hyoid displacement, so that's that bone that I was talking about that we need to move up and forward, and is quite often reduced the degree of movement for people with MND. We saw a decrease in how much that hyoid was moving over the initial no treatment period, and then an increase following the treatment. And the timing of the bolus of the food moving through the throat, that actually decreased slightly, but statistically significantly. So that shows that people were swallowing slightly faster. However, with the number of assessments that we did, there were many that we didn't see any statistically significant changes in, and I think this is something to be very aware of and to take from this study as well. So the timed water swallowing test and test of masticating and swallowing solids didn't change in this study, and none of our ultrasound measures changed, which is probably more to do with the use of the ultrasound tool than it is with the measures potentially. And then the other measures taken from the video fluoroscopy didn't change either. And as I mentioned before, no one tolerated the manometry. So I guess the important takeaway messages from what we learned from this study is that the therapy itself was not harmful. So there was no evidence that anyone had any decreased outcomes as a result of the therapy. And it may be helpful. So as I said, we did a lot of outcome measures because it is very much exploratory research at this point. This is the first time that this type of research has been trialled with people with MND. So I think given the large number of assessments that we did, the ones that we did see changing, the way that statistics works means that potentially these are just spurious findings. They're just findings that appeared because we've done so many assessments that potentially that they are not true significant findings. But then we still have to consider potentially they are true findings. So yeah, it's something that just shows we need to do a bit more investigation. In terms of the results following the treatment, the main study versus the pilot study, we saw more convincing results, even though it was a smaller number of people following the pilot study. So this could be due to the number of weeks that we did the therapy for. So the 4 weeks in the pilot study may have been a more adequate amount of time to help to increase those functional swallowing outcomes. So I think basically this is showing us that there's hope that this could be potentially beneficial, but there's not compelling research to say that it is something that I would recommend to all patients at this point. So I think more research would be beneficial to follow up from this research that's been done, looking at a longer treatment protocol, and then also trying to figure out if there's a better way of deciding which patients should undergo the skill training that we've just used versus the strength training that I spoke about that has been researched by Emily Plowman over in the United States. So I think looking at trying to, increase the or streamline the way that we do assessments to try and figure out who needs what would be beneficial as well. Because as I touched on earlier, MND has such a vast array of presentations in terms of swallowing outcomes as well. Just to bunch everyone into this is the answer for MND it's not ever going to really work. So yeah, that's basically what we've been doing over the last 5 years. So just want to thank everyone who was involved in the research, my supervisors, as well as all my collaborators for everything that they contributed. And of course, the MND registry, who were phenomenal in helping to get the information out to people within those Auckland and Christchurch regions, and the MND Association for their assistance as well. So happy to answer any questions that anyone has at this point.
Thanks, Paige. Can I ask a little bit about your patient cohort? Did you have a feel for whether the initial swallowing capacity of those people was affecting their ability to respond to the treatment? You had a bit of a run-in, but not really. So
yeah, so I think with the cohort that we had here, it was such quite a wide array of the severity of the dysphagia at the initial assessment. So it ranged from people who sometimes feel food sticks in their throat a little bit to people who are, coughing and choking every time they have anything to drink. So I think in terms of those who had quite a severe dysphagia, we wouldn't really expect as much this therapy to reverse and improve dysphagia as we would potentially to help prolong the swallowing that people have. So potentially those ones who were further along in the disease progression, who had more advanced swallowing symptoms, it's potentially not the therapy for them. They did have a little bit more trouble participating in as well, because of course the therapy is swallowing. But for the most part, everyone could complete the therapy and get swallows going with.
So they could get their swallow sitting within that target box, even if they were quite severe. They had severe swallowing issues.
Yeah, some People definitely took longer than others to try and increase that. It's quite a hard task. So the other thing I didn't mention is that actually, as the task went along, if people are doing really well, that box got smaller, so it got harder, just to keep increasing the difficulty. If they were consistently missing the box, it got bigger to make it easier. So I think by the end of the therapy, definitely, so we did run stats on how well people did. So overall, the trend was that everyone got better. And I think by the end, everyone was definitely improving and achieving a higher score in terms of how close they were to that very centre of the box.
Mm-hmm. We have a question that's come up in the chat. Sorry, the name is coming up as KLM2, so I'm not sure what your name is, but the question is, did any of the patients have difficulty managing saliva, and did this improve the management of this?
So that's not something that we investigated in itself in terms of whether saliva management was improved. I think I can't recall anyone who had a lot of difficulty with saliva management. I think everyone was at that more mild to moderate severity of their swallowing difficulties.
Great. Does anyone else have any questions? Feel free to throw them into the chat if you don't want to turn your camera on or unmute yourself. And if there are any questions for our speakers who are finished that you want to throw into the chat, then perhaps they can respond to them after at the end.
Sorry, can you hear me?
We can. Thanks, Kate.
I noticed that some of the medication, Nuidextra, was mentioned there that some of them are on. Was that the American subjects, or because I know in New Zealand, when I went to a conference in the States some years ago, they were using that for the thick, gluggy saliva that a lot of people with MND experience. But for some reason, it's not something that the medical professionals are keen to prescribe here.
Yeah, so that was the American participants. I think in terms of the research, it's kind of still mixed, and I'm not by any means someone who does research into medications or anything like that. So, but yeah, it's still quite mixed whether or not they're actually beneficial or not.
Thank you.
Perhaps Janet or one of the other neurologists could comment. My feeling was that Nuidextra is for pseudobulbar affect. I'm not sure of any effect on saliva. If anyone wants to weigh in, you can always pop it in the chat. Nope, possibly time to move on then. Thank you, Paige.
Yep. Okay, and like as Emma said, if anyone has any other questions, just put them in the chat if you think of them as we're going along. Thank you very much, Paige. That was wonderful. I might just, if you could, brilliant. Okay, so next we've got Dr. Michael Boyd, and just so people are aware, we'll take a quick, probably 5 minutes, just a quick toilet kind of refresher break after Dr. Boyd has presented. But first of all, I'd like to welcome Dr. Boyd. Dr. Michael Boyd is a nurse practitioner and an associate professor with the School of Nursing and Freemasons Department of Geriatric Medicine at the University of Auckland. Her main research interests are care of older adults in the community and residential aged care and advanced nursing practice. Dr. Boyd and her team have been conducting a research project investigating end-of-life care in dementia and neurodegenerative conditions who have been living in long-term care facilities. She also practices privately as a primary care provider in aged care facilities through Equinox Health Limited. So welcome today, Dr. Michael Boyd.
Thanks. It's great to be here, and thanks for the invitation. I'm going to go ahead and share my screen quickly. Hopefully. There we are. So just a couple of acknowledgements. We were funded for this project from the National Science Challenge, and we really appreciate that funding. Just a couple of things. So I work in residential aged care. This research project wasn't specifically about MND, but it was definitely about the end stage of chronic illness, and certainly MND would be affected by that. So one of the things that I think people don't necessarily realize is that New Zealand has one of the highest rates of death in residential aged care of any developed country, and that rate has been going up quite significantly over the last 15 years. This is some research that was done by Heather McLeod, who does some great epidemiological research on end of life in New Zealand. And one of the things that we know in the last 15 years is that deaths in residential aged care has increased 8%. And we feel it in residential aged care. We certainly do quite a bit of end of life care. But what's interesting about that as well is that where did these deaths, where did they come from? And it looks like there's fewer and fewer deaths in hospital over that same period. The deaths at home have stayed relatively unchanged. The deaths in hospice units have basically been relatively unchanged. There are fewer, some of that came from better public classification of deaths as well. And certainly for my practice, what we see in the future is that this big bulge, so this is 221 right about here, and these are deaths projections and the age of death. So one of the things that we see is that the deaths under 65 are really going down, but the deaths of those that are over 85 are, that is where the majority of people will be dying, is after their 85th year. I'm not aware, and maybe you guys can tell me what the average age of death is for somebody with MND. Do you guys know that by any chance? Anybody know that? I'm sure it's younger, of course. It's a much more progressive and fast-paced disease process. But I think it's important to understand that if you reach 65 years old, your chances of living in residential aged care and therefore dying in residential aged care is about 50%. So, one of the things I like to kind of have us consider is that 24-hour care, whether that be in residential aged care or with somebody who is caring for you 24 hours a day, is part of the continuum of life, and it is the continuum of healthcare. All of us will likely, before we die, become frail in some form or another, whether that be dementia or MND or cancer or whatever. Most of us will need a period of 24-hour care. And so I think it is important for us to see that 24-hour care need, again, whether it be residential aged care or whether it be somebody taking care of you 24 hours a day, wherever that might be, is part of the continuum of care. So I was interested in knowing these statistics. I was very interested in the quality of that end of life care. There was just really not much out there about the quality of life and the quality of death for people that were dying in residential aged care. So with the help of the National Science Challenge and also the Perpetual Guardian Ted and Molly Carr Trust, we were able to fund a research study that replicated the protocol by a Belgium group. And so we replicated that protocol. The Belgian group went on and, to do a study of 6 European countries. So we were able to compare our research with those 6 European studies, countries, which has been really helpful. We had a representative sample of New Zealand aged care facilities. We stratified them by size, profit or not-for-profit, and region. And then what we did is we said to these facilities, once they were recruited, tell us everybody who dies in the next 3 months period. And then we had our research assistants, Deborah Balmer and Susan Foster, follow up within a week or so after these deaths, and to do retrospective surveys of the staff. These included registered nurses, healthcare assistants, doctors, and managers, and qualitative interviews with the staff and family as much as we could. There were 61 facilities representing about 3,700 beds, and in that, during the study period, we had 286 deaths, and we were able to do 113 interviews with staff and family, but we were able to do the post-death surveys with all 286 deaths. So this is on the left is kind of a traditional, it's a representation. This is not that Lynn Adamson diagram there is not based on research, it's based on experience. And so they developed this, I would say, guide, I guess, of different types of deterioration before death. And they had, in the top here, they have mostly cancer. What we see with cancer is that people do pretty well until the very end, and then death. Now, this is changing. It's amazing with the new cancer drugs. I had a gentleman who came into the facility a couple of years ago, and he had a renal carcinoma, and started a new regime of medications from the oncology unit, and he went home. I mean, that just never would have happened before. So the new cancer therapies are changing this traditional view. Then we have what we called long-term limitations with intermittent serious episodes. And then they have a thing that they call prolonged dwindling. I'm not a real fan of that term. That's the term they used. I think it's a horrible term myself. But this middle one is really more of what we see with people with heart disease and lung disease. They have periods where they get really sick and you think this is the end, and then they bounce back, but they're never quite the same as they were before. And this lower one would be people with dementia, where they have this kind of long period of decline, and there's nothing real dramatic that happens usually, but it's a long period of decline. My thinking is that people with MND are somewhere in between these two. I think they have periods where they would have lung infections and they would have all sorts of issues, but that they would also have this longer period of decline. So using that kind of model from Lynn Adamson, that's widely used in describing trajectories of death, we used our sample and divided them up by these three: cancer, dementia, and chronic illness. Now, chronic disease, I believe that's where the MND folks would be in. They would not be classified as primary diagnosis of dementia. Their primary diagnosis would have been chronic disease. So as you can see, 17% of people in residential aged care die of cancer. 28% of people will die of chronic disease, and 55% of people will die of dementia. And I think that's the other important thing to understand about 24-hour care, is that the majority of people in 24-hour care are there because of cognitive problems rather than just physical disability. So residential aged care length of stay. Now, this was quite interesting for me because, again, I work in residential aged care. I experience the changes that have happened over the last few years. A lot of those decreased deaths in hospital are discharges to residential aged care for end-of-life care. That's a real change, and that's been a real massive change over the last 15 years. And you can see this, it kind of shows up in this length of stay data. People that are discharged from hospital to us for palliative care, for instance, are mainly cancer, and their median length of stay is a month. For those with dementia, their median length of stay is 15 months. and for those with chronic disease, it's 17 months. The mean, of course, is much more broad than the median, because we have people stay with us for 10 years, and then we have people that are with us for a week. So there's a huge variety. But I think this length of stay data is really important for us when we look at quality of life and socialization. And one of the things that's been talked about more and more is that there are more deaths in residential aged care. That's great, but from my perspective, somebody caring for people in residential aged care, they live in residential aged care. They don't just die in residential aged care. And I think personally, I think it's a very big mistake just to view residential aged care as a place where people die. I don't think it does justice to their quality of life. So although this study was about end of life in residential aged care, I think it's very important to keep in mind that people live in residential aged care until they die. So a couple of things are also interesting. There were no unexpected deaths with people with cancer. We expect them to die. But that's not the case for chronic illness, and that's not the case for dementia. There is a significant amount of people that, live longer than we ever expected them to, and people that die sooner than we ever expected them to. I had March was a particularly busy month for end of life care for me. I don't know why March was. I think it's the change in season. I don't know exactly why, but I was doing helping somebody die about every other day. Did about 12 deaths in March. And what's interesting about that is I had a woman just last week who had dementia. She was slowly deteriorating, and then she had a heart attack. So you just never know when somebody's going to die. And I think this has a real implication for palliative care models of care. One of the models of care, and where the palliative hospice model of care came from, was from cancer. It was started in the 50s and the 60s, and that idea was, at that time we didn't even say the word cancer. I think that's a really important thing. Just as an example, Rachel Carson, who wrote Silent Spring, was a great scientist and changed the whole idea of ecology. She was a scientist, but in the 60s she got cancer. They never told her she had cancer. So that's where hospice and palliative care came from, is this idea that we weren't caring for people with those diagnoses. What's happened over the last 20 years, 30 years, 40 years, is that there are more of us that will die over 85 years old. There are more of us that will have a longer period of decline, and we will need a year or two of 24-hour care. And that is, the idea that we can prognosticate death, that we know when somebody is going to die, is, in my world, is not, it doesn't happen. There was I can't remember if I have a slide on this, but there was a study that was done out of Canada. And one of the things that we use in palliative care models is the surprise question. Would you be surprised if this person died in the next 6 months, year, depending on the question. Now, if you walk into residential aged care and you look at the folks that I care for that require 24-hour care, I wouldn't be surprised, but I would not be surprised if they lived a couple of years either. So this idea that we can prognosticate death and know when somebody's going to die, in my opinion, is quite false. So what we found then was we looked at the symptoms at the end of life. We looked at physical symptoms such as pain, breathlessness, skin breakdown, and we looked at psychological symptoms, whether they were calm, whether they were depressed, fear, anxiety, agitation, and whether they were resisting care. And what you can see is that for the lower scores mean more symptoms. It's a little bit anathema of the way that the study was designed. But you can see that people with dementia have more symptoms at the last month of life than people with cancer or people with chronic illness. Now, what's interesting also is when you look at psychological symptoms, the people with dementia, they were scored as not having as many psychological symptoms. A lot of this is because of the cognitive impairment, and they can't tell us what they need. So I think that that's, you can also see this difference in cancer, where they can probably tell us what they need and how they're feeling versus somebody with dementia. So this is the last month of life. Again, this is the physical symptoms, and you can see these black parts of the bar graph here are daily incidences of pain versus cancer and chronic illness. Chronic illness also came up as having quite a bit of pain at the end of life compared to those with cancer. Shortness of breath, there were more people with dementia that had more shortness of breath than people with cancer. The same with skin breakdown. There was more skin breakdown. Now, skin breakdown is a kind of an interesting thing as well in my world of working with very frail older people, is the skin is an organ, and just like organs fail, your kidneys fail, your heart fails, your brain fails, your skin fails at that very last a little bit of life. And so that doesn't surprise me. Yes, there are pressure injuries. Yes, there is poor care, but really we also see skin breakdown that happens as a part of the end of life experience. So this is the last week of life, and this is also interesting to us because if you looked at physical distress, dying symptoms, emotional distress, well-being, there was no statistical difference between dementia, chronic illness, and cancer. And what this means to me, and certainly my experience as somebody who cares for a lot of people that are dying, is that dying is dying. That last week of life, there are a lot of really good palliative care measures we need to put in place. There's a lot of communication that needs to happen during that last week of life. But the last week of life, no matter what you die from, that dying process pretty much looks the same. This was kind of brought home to me personally. Last year I was on sabbatical and happened to be in the same town as where I had lived for a long time before I came to New Zealand. And a friend of mine from college, we were really, really good buddies in college, was diagnosed with cancer. She was my age. And she actually died of cancer, and I had the privilege of being with her and her family during that last few days of her life, and doing a lot of end-of-life care in residential aged care and helping her die at her home. There was no difference. It's the same process, and I think that's an important thing for us to consider, particularly if you think the way things are set up in New Zealand for end-of-life care. What we found in our study was that 30% of people in residential aged care that died of cancer had hospice services also engaged in that process, while 5% of people with dementia had hospice services engaged in that process. And so you've got to ask yourself, why is there a difference between those that die of cancer and those that die of dementia? And it's just something for us to consider as a society, I think. So this is what this is we were able to, because we use the same protocol as the European colleagues, we were able to compare the quality of death symptoms for people in New Zealand compared to the UK, Belgium, Finland, Netherlands, and Poland. And you can see that New Zealand, actually we rated quite well compared to our European colleagues. Now, one of the things that's interesting is there is a lot of death that happens in residential aged care, and a lot of death that happens in hospital, a lot of death that happens in homes and in hospices. What we haven't done in New Zealand, and if there's anybody out there looking for a master's degree project or a PhD project, what we could do is compare the end of life experience for people with in home that die at home and die in hospices and die in hospitals and die in residential aged care. There was just yesterday, I didn't get a chance to put a slide up about this, but there was just yesterday a study that was released out of Australia that actually looked at this, that looked at comparing the quality of death, and they did a very similar post-death survey, comparing the symptoms at the end of life for people that died at home and those that died in residential aged care. There was no difference. The quality of death was about the same. The main difference that they found was that the communication was better in residential aged care. That's just because I think we're a little bit more aware of it. And also people that died at home used the hospital a lot more than people in residential aged care. We also, with our qualitative work, I really enjoyed the results that we got from this qualitative work. Basically, a good death. We asked, families, we asked staff what a good death means, look like to them. That good death idea is interesting. There is a Western view of developed countries, high income countries, of what a good death is. A good death is peaceful. That's one of the things that families always tell me when I'm talking to them, when I'm giving my condolences to them and talking to them after the death. Whether it was peaceful or not is very important to them. But what that means for me as a provider is peaceful means really good syringe drivers. It means really good morphine and really good midazolam, and that I've got the Serenase right. And because we have this idea in our Western culture that you lay down and you shut your eyes and you get really quiet for a day or two and then you die. That's not always the case, of course. That is not always the case at all. People have end-of-life delirium that is quite distressing to families. So a good death, that meaning, I think, is an interesting philosophical discussion. Another part of that is death with dignity, and I'm not going to go into that at all, because that law change is coming in November and it's very controversial. But what is dignity? What is dignity? If you start to unpick it, what does that mean? I just read a lovely book called Inevitable. It's a brand new book. And this woman looked at end-of-life bills and things like that across the world. But one of the things she tried to deconstruct is this idea of dignity. And one of the things that she found in her interviews is dignity is keeping all your faculties, that your sphincters work, basically. That's a lot of what dignity is that I don't need 24-hour care. I don't need somebody to provide that personal cares. And that's, in my opinion, a wrong way to think about dignity myself. But that's what a lot of people are afraid of. And I find it interesting. So a good death. What was interesting for staff was that there are tensions for them, because what they see as a good death is somebody not dying alone. And so they try really hard to make sure that either there's a family member there or there are people without family members available, and that they try to be there for that person when that person dies. Now, you got to remember, these facilities, a nurse could have 25, 30, 35 people that she's caring for, and she's got this tension of she doesn't want this person to die alone. Now, the other part to that that's kind of interesting, and I try to talk to families about this, I don't know what, spiritually or philosophically, if people have a choice of when they die, I don't know. I say that a lot. It's a mystery. I don't know how this is. But just as another example, I had a woman who had early onset dementia. She'd had it for 12 years. She was in the last end stage of that. She was dying. And her husband was very devoted, an extremely devoted man to her. He came every day and to see her every day. And at the end, I try to tell families, like, don't feel guilty if you walk out of the room and the person dies. And sure enough, that's exactly what happened. He'd been with her 24/7, walked out of the room to get some dinner, and she passed away. She died while he was out of the room. So, it's again, this idea of good death is something for us to look at as a society, I think. Now, the healthcare assistants, when you ask them what is person-centered care, and that's a jargon that we throw around in residential aged care a lot. What is person-centered care? They can tell you the definition of person-centered care. It is about providing care for that person that is based on them and their needs and very individualized. They get that. What they get frustrated with is that they are pushed to get all the tasks done that they need in residential aged care. And that, for us in residential aged care, I think we're sorely misunderstood myself. I sometimes think to myself that I work and enjoy working very much and find meaning in an environment that's the last place anybody wants to go, which is quite interesting. So the outside view of the care that we provide in residential aged care is often negative. And what's interesting, there's been some research to show that for people, and I blame the media for a lot of that myself, but for people that have had experience with loved ones that have lived in residential aged care, their view of residential aged care is much higher than people that have never had any experience in residential aged care, which is why I feel like the Pied Piper of saying 24-hour care is part of the continuum of care. And it doesn't, because of ageism and because of our fear of decline and because of our fear of frailty, we view it negatively. And when actually there are some amazing people doing amazing work in residential aged care, but our staffing levels are pretty tough. We have HCA doing 6 other people. We've got, like I said, RNs doing 25 to 35 people. And you compare that to a hospital, you've got an RN doing maybe 1 to 6. You've got in hospice, you've got a 1 to 2 to 3 ratio. So, according to what we can see about end of life care in New Zealand, we do pretty well, and they're pushed. They have a lot to do. We also talked to GPs, and one of the things they talked about is that they kind of fall into residential aged care. I doubt there's a lot of GPs that know a lot about MND, to tell you the truth. A lot of them don't know a lot about dementia. A lot of them don't know a lot about end of life care. So there is very little formal training in dementia, frailty, end of life care. But what was interesting to us is most of them said they were surprised at how satisfying the work is. I find the work incredibly satisfying. It is having that long-term relationship with somebody and their family is incredibly satisfying, and being able to help them at the end of life is incredibly meaningful. Families were overall satisfied with the end of life care. So that's an important message. The families did not feel like they didn't get what they needed. But when you ask them what palliative care means, to them, when I say palliative to a family, they say when. And as I've said before in this presentation, I can't tell you when somebody's going to die. And so I avoid the term palliative myself. I will talk about goals of care. I'll talk about other ways of talking about, advanced care planning, those kinds of things. But when that question comes up of when will they pass away, I don't know. And I'm just really comfortable now and at this stage in my career saying, don't know. We'll do the way I describe it usually is I need to follow them. They're going to show me where we need to go. And I can't tell you where that journey is going to go right now. So just the take-home messages. Oops, sorry. The take-home messages are: primary diagnosis makes no difference in the symptoms last week of life, whether you die of MND, whether you die of dementia, whether you die of cancer, whether you die of heart failure. That last week of life it's just about good end of life care. people with dementia and chronic disease have more geriatric syndromes of concern for much longer. So one of the other things to remember, and I think this is true for MND as well, is that the last week of life, certainly there's a specialist knowledge that we need to have. We need to be really good at what we do in the last week of life. But for those of us that work in residential aged care, that last year of life is the hard one. You know, that last year of life is when we're trying to help them not fall and make sure they get enough to eat, and swallowing issues and behavior issues and caregiver burnout. And, you know, that's for me the hard bit about end of life care, is that last year of life. The last week of life, I think, is a much more straightforward process. You need specialist knowledge, of course, but it's a much more straightforward process than that last year of life. There's an ambiguous clinical course. Death is unpredictable. And for us in residential aged care, and certainly for those that will be in residential aged care with MND, reversibility of deterioration is key. So that's why I say it's really important to know that people live in residential aged care. They don't just die there. And so that last year of life, we're constantly looking at, okay, is this a chest infection that can be reversed? Is this a swallowing issue that can be reversed? Is this a falling issue that can be reversed? You know, we're always constantly looking at, they're deteriorating, so what do we need to do to reverse that? And that's a real geriatrics, you know, fundamental premise, is that it's about reversing deterioration as much as possible. Traditional palliative care models, in my opinion, don't necessarily fit advanced frailty, and I think people with MND could be classified as advanced frail at the end of life. So one of the things that we developed as part of this research is the Frailty Care Guides. That's through the Health Quality and Safety Commission. The Frailty Care Guides are those guides that help you look at all the things that could be reversed. We have swallowing in there. We have elimination, guidelines for that. We have chest infection guidelines. So there's 26 different guidelines to help us look at, okay, so how, what do we need to look at before we say this person is dying, that actually this is a reversible condition. The other thing that's, I think, important is the ability to say what you need. And of course, those people with dementia have a very low ability to express their wishes. But for everybody, there was a lot of family members that were involved in care. And I think that a lot of my job is certainly to look after the frailest in the population, but also a lot of that is about very good communication. And I do a lot of phone calls. I do a lot of family meetings, because I know as a provider that the best thing I can do is to talk with the older person and the person that's frail and their family. So frailty, again, if you look at this is the Rockwood Frailty tool, they've separated out terminally ill from the very severely frail, and I agree with this, because terminally ill it's a different process than the very frail. I'm kind of going over, so I'm going to just move through this. One of the things that we don't do well, and I imagine that's probably true for MND, is a bereavement support. I'd like to see more hospice in that bereavement support for people with dementia, as well as people with cancer, and as well as families that are dealing with the death of somebody from MND. And then the last but not least is advanced care planning. Sorry, I lost my thing. I do this every once in a while. There we go. And advanced care planning isn't just CPR. That's, it isn't. It is about EPOA. Yes, we talk about CPR, but for us, and particularly for people with MND, there's a time when you need to say, hospital doesn't have anything to offer us anymore. And that's a discussion that needs to happen as well. Through the Health Quality and Safety Commission, we do have an advanced care plan guide that I find really helpful. in residential aged care. It's a little bit more straightforward than the other one that they have available. This is specifically for people in residential aged care. It asks the real basic questions like EPOA activation and those kinds of things. I like to have good conversations about advanced care planning, but one of the parts of that conversation that I think are really important that makes the conversation real and meaningful is, what are they worried about? What do you know, what's the most important thing to you? What are the things that you worry about? What are the things that your family worries about? That brings that conversation into the reality of who that person is, rather than just talking about CPR preference. So again, trying to say, is this restorative care? Is this on-site active care? We're going to give you an antibiotic, but really hospital doesn't have a lot to offer us from now. Or are we now thinking about no antibiotics at all? Last but not least, I have a lot of families that are, one of the things that I think we underestimate greatly is the transition from being at home to residential aged care is one of the most difficult, most uprooting transitions that we have in our lives. And yet we get no support at all formally for that transition. The person that's going into care doesn't get any psychological support. The family doesn't get any psychological support. I wish we had social workers that are available to do this kind of work. I think it's a piece that we're missing in our healthcare. So when I'm working with families, I try to have compassion for these families, which is different than empathy. I don't want to put myself in their shoes at all. That just causes me to burn out. What I want is to have compassion, which gives me the separation, but allows me to see where they are. So these families are grieving. These families are guilt-ridden. They feel really badly that they can't provide the care, that 24-hour intense care at the end. They feel overwhelmed. They feel disappointed. And many of them feel quite angry. And so sometimes we're in the path of that anger, which is not always easy, but if I can have compassion for that family, it does make it easier. So that's our research. I hope that was helpful. And I'm happy to take any questions. Gone over a little bit, sorry.
That was wonderful, Michael. If anyone has any questions that they don't feel brave enough to ask verbally, feel free to pop it in the chat. I just want to ask a little bit, Michael, about, you asked the question of how old are people when they die from MND, and we did a study a few years ago where we showed that most people were between 70 and 79.
Okay.
But, there's really two groups of people with MND. There's people with either weak or unknown genetic factors, and there's people with strong genetic factors. And people with strong genetic factors can die significantly earlier. Do you tend to, what happens for people who aren't actually aged when they die from MND? They're dying at home, and I think your master's project around looking at the differences between dying at home and dying in aged care is very relevant to MND. And can you comment on that at all? What happens to those people who are dying of MND at a younger age?
Yeah, it's a really good question. And I don't think we have much information about that at all. And so one of the things that the hospices can get involved in that last stage, and I think that's a really important resource, is hospices can get involved. But that does mean that you've got a caregiver at home who is probably pretty tired. And I think that, again, that's the piece. We all, again, not only do we want a good death and a dignified death, we all want to die at home, right? And that's not always possible. So supporting that caregiver is absolutely imperative, but we don't always have the home care resources to provide the level of care that's needed. We do the very best we can, get hospice in, get home care in, but that's a tough road to hoe for a lot of families.
Thanks. Any other questions?
You mentioned that you've done the study on the quality of death at home versus residential aged care for the person. Is there any research done on that quality or that time for families
That's a really great question, and not that I know. Well, I think there are some, but I haven't read it recently. And again, from our research, the families were satisfied. There has been some work by Jackie Robinson and Maren Gott, where they looked at what's called the Voices study. And the Voices study did a post-death questionnaire to the families. And again, there was some really, families were very satisfied. There were a few some families that weren't satisfied, but that was true for hospitalization as well and for home death. So it's the idea that there's this, one of the reasons we did the research was there was this kind of, again, there's a negative view of aged care, just in general. And so there was this view that, oh, it must be bad. It is not. It is not bad. It's actually, that relationship makes a huge difference in that end of life care.
There's also a question that's just been put into the chat. So this is from Carolyn Clemens, and she says, thank you so much, Michael, for sharing your knowledge and experiences. Do we have an idea of the reasons why more people are dying in residential care? Is it that more people are now living in residential care for a greater part of their life?
That's a great question. And part of it is that we are all dying older. And one of the things we all had hoped for is that there would be a compression of morbidity. And what that meant was that, yes, we're all going to live longer, but we're not going to be sick for very long, right? So that's kind of this lovely idea that you sit in your chair and you die at, 93. Well, that never happens really. Every once in a while that happens, and good on them, and glad, I had an uncle that happened to, but that doesn't happen very often. The majority of people will have a 2 to 4 year period of frailty before they die. And so as the age of death has increased, we don't have a compression of morbidity. We actually, looks like people need care for longer than the older they get. And so I think that's part of it, the aging population, but also because of the residential aged care is doing more palliative care, traditional palliative care, and people are dying older. If you look like you no longer are benefiting from hospitalization, right? There's nothing more they can do. Then, and you're older and need 24-hour care, you are going to be transferred to residential aged care for your end of life care. Does that make sense? So people are being discharged from hospital for end of life care much more than they ever have before. That's one of them. And then the second one is just people are dying older, and if you die older, you're frail and you're going to need 24-hour care.
No, that makes sense. And there's a message from Beth. She just says, thank you, Michael. I found many new concepts for me in there. Tonight I'm going to see the Father. I'll keep this talk in mind. Thanks again. Yeah. And Kate has also said, fabulous presentation, keeping it real and practical, so important. Great. So thank you for that. If anyone has any other questions, you can put them into the chat. But I just thought we might just take a really, really quick 5-minute, just stretch the legs, and then we'll come back and we have our last presenter then, Grace Chen. So, and thank you very much again. Okay, everyone, hopefully you're all back on the line. Sorry, that was a really quick break, but just in the interest of time, we need to keep moving. I am delighted to introduce our next speaker, Grace Chen. So Grace Chen is a research officer at the Center for Public Health Research at Massey University with an interest in occupational and environmental health and neurodegenerative disease epidemiology. Grace has been involved with a number of epidemiology studies in the field of occupational health. She is currently working on an interventions to reduce occupational disease study and is also working towards her PhD with a study on investigating the relationship between motor neuron disease and a range of known and suspected occupational and environmental exposures. But welcome, Grace, this morning, and I will let you share your screen.
Yeah, good morning. Yeah, just try to. Yes, good morning. I'm going to talk about our recent findings from our MND studies. Here is all the research who involved in this study. And this study was funded by HRC. So in this study, we try to investigate the associations between occupational environmental exposures and the risk of MNDs in New Zealand. The study involved 321 MND cases and 605 population controls. Case was recruited through Motor Neuron Disease Association register and also through the hospital discharge data around the country. Controls were selected from the New Zealand electoral roll with two controls for each case, frequency matched age and gender. Both cases and controls was recruited between 2013 and 2016. We collected information from both cases and controls on personal and demographic details, residential history, lifestyle factors, and full lifetime job history. The identical data collection method was used for both case and controls, which include a face-to-face interview, telephone interview, or a post questionnaires, depending on the participant preference. Quite interesting, more than 60% of cases prefer a face-to-face interview, and more than 60% of controls prefer a telephone interview. All participants were asked to list all jobs ever held for 6 months or more, and for each of the job, participants provided information on job title, industry, the year and the month in which the job began and ended, the type of the exposure, which job task related to that specific exposure, and how long exposed to, and how often they exposed to, such as how many hours a day, how many days per week, and how many weeks per year. So in total, more than 6,300 jobs with a full job history was collected from 2,700 occupations and 3,100 industries from the questionnaire. And more than 10,000 data on the self-report job-related exposures was also collected. This detailed information provides us a good study power and also an excellent opportunities to investigate the associations between occupational, environmental exposures and the risk of MND in New Zealand. So the first part of the presentation here, I will show our findings on occupational exposure to electrical shocks and extremely low frequency magnetic field and the risk of MND. So in our study, we look at associations with never exposed to electric shocks or EMF compared to never exposed at work. And we also examined the associations for duration of the employment and the cumulative duration during the lifetime. As there was no available measurement for work-related electric shocks or EMF exposures in New Zealand, to assess the occupational exposure to electric shocks or EMF, so we have to adopt our international job exposure matrix, which we called GEM. So the shock GEM was based on pooled national accident registry data from 5 different European countries and reflects the potential for electrical injuries for each occupation. The EMF GEM was based on magnetic field measurement taken on or near the workers from 10 different international studies. The characteristic of study populations are shown in this table. As we can see, around 64% of cases were male, and most of the cases were over 60 years of age. And there was no significant difference between the cases and controls in terms of smoking, ethnicities, education, socioeconomic status, and the numbers of jobs they worked for a lifetime. So on average, both cases and controls had around 7 jobs in their life. We found an elevated risk for people who had ever worked in a job with potential for electric shocks compared with people who had never worked in such job. The odds ratio was 1.35, and we also observed a 2-fold increase in risk for people who never worked in a job with a high potential for electric shocks, such as electricians or power line workers, compared with people who never worked in those jobs, such as banking officers or normal office workers. Analysis by duration suggested a non-linear association. The risk was increased for both short duration and the longer duration of the employment. We found that people who worked for less than 3 years and people who worked for more than 24 years of the job with a high level of potential for electric shocks both showed an increased risk. The odds ratio for less than 3 years was 4.69, and for more than 24 years was 1.88. And we found no associations for the intermediate durations. So this suggests that potential for electric shocks may be higher in short duration jobs, during which workers had not yet gained experience to prevent such jobs or such risks, and observed increased risk for the long employment in jobs, such as more than 24 years with a high potential electric shocks, may be explained by accumulated minor shocks over a longer period, or by a higher chance to have a big single shock when the employment duration is longer. And we found no associations with occupational exposure to EMF. So in these studies, we found occupational related electric shocks and MND, and did not show associations with exposure to work-related EMF. So these findings was consistent with our previous findings on electricians and MND risk. So the second part of this presentation will report our findings on 11 different occupational exposures and the risk of MND. There are the 11 exposure categories in this slide. So in this part of study, we examined associations with ever exposed to a particular occupational exposure compared to never been exposed to that particular exposure. And we also examined the associations for duration of the exposures and the risk of MND. There are some strong associations between specific exposures and MNDs, as indicated in this table. 2 out of the 11 occupational exposure categories, a fumigant and pesticides, both showed a statistically significant increased risk for MND. In addition, 2 other categories, which are fibers and other chemical products, also showed an elevated risk for MND, but this risk was only observed for women. For these exposure categories associated with an increased MND risk, association for specific exposure within each categories are present in this table. I'm sorry, a little bit smaller than the font. So within these 4 categories, a more detailed analysis indicated that all fumigant subcategories showed increased risk, but only methylbromide was statistically significant. This risk was only found in men, as there were only few women was exposed to methylbromide. So in our study, people who reported exposure to methylbromide at work, the exposure occurred mainly in horticulture occupation, where the methylbromide is currently no longer in use in New Zealand. And among the 3 main pesticide subcategories, which are herbicides, insecticides, and fungicides, statistically significant increased risk was found for insecticides and fungicides. And this risk was also found for both genders. Herbicides is also showed an elevated risk, but this risk did not reach the significance. Among the fiber subcategories, women who were exposed to textile fibers was associated with an increased risk, which not observed for men. And among other chemical product subcategories, we observed increased risk for exposure to disinfectant and cleaning product. And this risk was again only found in women. We also look at the associations between MND and the duration of exposures. We found that among these exposures with an increased risk, all showed a positive duration response relationship, which indicated that the risk increase as the job duration increase. So, in the conclusion, our study showed a several occupational related exposures with increased risk of MND. And the key finding of these two papers are, first, work-related exposure to electroshocks, and second, the work-related exposure to fumigant and pesticides, in particular insecticides and fungicides. Well, these results need to be interpreted cautiously because we haven't got the direct exposure measurement, but they are consistent with our previous studies on occupations and MND risk, especially the horticulture occupations and MND risk. And in our study, around 29% of men and 10% of women who reported they was exposed to pesticides, either in work or in the work environment setting. So that really showed a strong indicated increased MND risk in New Zealand. So I think from this study, we really think about it. A lot of occupational exposures was associated with MND in New Zealand. And that is my current work on. So we look at the lifestyle and risk of MND. So we're going to look at smoking, alcohol, physical activities, and head injury, spine injury, and emotional trauma. And it was quite interesting. We did a preliminary analysis, and head injury and emotional trauma showed a quite interesting result. And I probably will be able to update all those results in the next couple of months' time. And thank you.
That was great. Thank you, Grace. I just have one question, just in terms of the pesticides and the different kind of environmental and occupational exposures that you noted. Has there been studies done in other countries to see if they show similar results?
It is quite some countries showed pesticides was associated with MND, but some countries didn't. So it's quite complex result. Mm-hmm. But most of studies, they couldn't separate pesticides as different categories. So they combined insecticides, fungicides, and timber preservative as a whole category. So for our study, because we have intensive data, so we can actually look at in each subcategories, look at insecticides, fungicides, or even timber preservative. So that was quite interesting because we called pesticides as a group, but actually each of them had different chemical involved. So we find out those quite interesting with our study is some people, they applied pesticides by themselves. Some people just working in the environment when the people sprayed pesticides. For example, like fruit pickers, they say, look, I involved with pesticides, but actually I didn't apply that by myself. So we did an additional analysis to separate those two groups, just try to say, if you work at work, when you're using pesticides by yourself, or you just work in the environment when the people sprayed pesticides before you come to the work, or even when you at the work. And the both groups showed an increased risk, but definitely the pesticides applicators showed a really, really high odds ratios. So this is really, this was quite consistent. Is when you apply to job, the intensity of exposure to the pesticides and when you work in the environment was slightly different. But I think interesting thing is in this study is the quite high proportion of the people for both case and controls, around 39% of the study population said, look, I was exposed to pesticides in my work. I think those quite high proportion in New Zealand that we need to really think about, what we can do with reduce pesticide exposure, or what we can do with get better PPE or personal protection when those people to apply for the pesticides in the future.
Can I follow up? I have a few questions, Grace. Thank you for that.
Yes.
Nice to, well, I'm not seeing you, but nice to have you here.
Yeah, I'm sorry. I don't know what's going wrong with my camera. Seems they just suddenly died.
That's fine.
Yeah.
So first of all, can I just get an explanation of the odds ratio? So does that mean that for a person who's been exposed to the particular environmental exposure, the odds of them being a person with MND are 3 to 1? Is that what the odds ratio means? Can you explain that a little bit more for us?
You mean, what do you mean 3 to 1? Sorry, I couldn't really follow. Oh, you mean that's probably have, 3 times higher of the risk to develop the disease if you expose. For example, I just get my slide. For example, with the insecticides. So sorry, let's get that back. Yeah. For example, we look at for fumigants. That's probably easy. So for mesobarma,
your slide hasn't changed, Grace.
Oh yeah, sorry. I just try to go back.
Okay. Yep.
Yeah. For this, see, when we look at for mesobarmide, this odd ratio was 5.28. That means for people who exposed to mesobarmide had 5 times higher risk to develop the disease compared with people never exposed to mesobarmide.
So does that mean that when you're asking a group of 600 controls and 300 people with MND, you look at all the people who've been exposed to methyl bromide, and actually the likelihood that they fall into the MND group is 5 times higher than
the controls? That's right. Yeah.
So do you, I mean, that's really interesting. And I think there's maybe some things that we can do with cell models. Maybe we could put some of those chemicals on cells and see what happens to some of the major motor neuron disease proteins in response to those. And I think probably anyone who's ever read a newspaper here and cares about MND will have heard the speculation that methyl bromide in the ports of Nelson might be involved in a cluster there, although that was refuted by the medical examiner at that time.
That's right, yeah. But the interesting thing is, because now with the mesobarmide, but internationally, they banned for most of areas. In New Zealand, only use as for the import goods. It's like, we still use
they're trying
as
to recapture that gap, don't they?
But the interesting thing is, in our study, we find out mesobarmide are mainly used as a soil fumigant for the greenhouse workers. So that is then they use as fumigant for the soils. We're not allowed to use that in our horticulture, but it's not meant to expose to mesobarmide. It still have the risk. But I think with that, like you said, we can do that with mesobarmide, maybe with a couple of insecticides.
Yeah, I think that would be interesting.
Yeah, I think that will be interesting because with insecticides, I didn't show in these slides, but in our study, we actually separate insecticides as 5 different groups because with different chemicals. And then we find out all of them was significant. So I think this is another thing we can discuss later on.
Yeah, that sounds great. The other thing I wanted to kind of unpick is the difference you have. Some things you have that are affecting females and not males. And I'm wondering if there are some instances where you might have one particular person or even a family of people with motor neuron disease that appear to be driving that effect, and that the family might work in the same industry and be exposed to the same things, that they actually have a familial risk factor or a genetic risk factor that you're not accounting for in your analyses. Is it possible that some of these could be driven by just a few individuals who are related or in the same industry and actually have a gene that's causing their motor neuron disease?
It can be, and I think the downside of this study is because we can't get all the details with all the cases, either they're familial MND or just sporadic, because they haven't got that details. But I think the thing is, when we look at the woman for the textile fibers, the average was 2.49, and actually it was quite a large group. But I think, we can really look at that, take those cases out, especially for the woman's case, and see what happened with their families. But I think the thing is, we need to interpret these findings. With the textile fibers, there was a group of things like carpet workers or people working for the wools and working for cottons. And maybe not only the fiber, maybe it's the process, they process the fiber, like they put a dye in the fiber, or we know in the carpet industry, they just put pesticide, put insecticides to treat the fiber or treat the carpet. So I think there was kind of mixture sense. We need to really dig in, see what is really the real factors. Yeah.
Yeah, absolutely. I think when you're seeing the same effect in males and females, it's easier to understand the biology behind that.
That's right. Yeah.
In fact, when you look at textiles, it seems to be protective in the males because you've got
a
ratio. So that's something that definitely needs more explanation. But yeah, I'd love to work together on seeing what these things do in cells. Sorry,
I've
no, definitely. Anyone else has some questions for Grace? I'm sorry, I monopolized the questions.
I have a question, if you don't mind. Did you consider investigating the relationship between the environmental exposures that you've identified and the subgroup of MND? So like if it's a bulbar onset or a limb onset, or even the age of diagnosis?
Yeah, I think we look at the age of diagnosis, and that is the sense we put into our adjustment. Like, say if there's confounders, because we don't want to look at the race was compared with the age of diagnosis. But I think the thing is, in New Zealand, we can't get the exactly diagnosed with the subtype in our study. So that's the thing, we can't really put in separate group. We want to do that, but we can't really do that with our study because there's really no record. We get the letter from the neurologist, but most of them just said MND. So there's no subtype, and we can't really separate them.
Yeah, I think that's an interesting point, Grace. And from a patient's point of view, it's probably extremely important to know the subtype because the expected duration of disease or the longevity of a person with MS is much longer than the other subtypes, whereas bulbar onset can sometimes have a much shorter onset, has much shorter duration. But from the perspective of a scientist, when we look at the pathology, those subtypes are almost indistinguishable. Even when you have PLS, which is supposed to be a upper motor neuron disorder, we also see lower motor neuron pathology. So there's really no distinction pathologically at the end of life between those diseases. That it's almost like they kind of collapse to be the same disease.
And also, I think, from our study, we find out because we're doing the lag time. So we look, all the exposures happened 5 years before the diagnosis, happened 10 years, 20 years, 40 years. We find out, it's not much different between the exposure happened 40 years, 20 years, and 10 years. So this is really
what is that critical window?
Yeah.
Very interesting. Thank you, Grace.
Thank you.
Okay. Right, guys. Well, it's going on 5 to 12, so I think we have timed it perfectly. I just really want to say a massive thank you again to all of our speakers today. It's great to hear the fantastic work that you're doing and your contribution towards MND and research. I'd also just like to take the opportunity to thank the Motor Neurone Disease New Zealand, who they provide funding for the MND Research Network, and without their support we would have been unable to provide this information here for you today. This is the first of our MND teleconferences this year. There's another one scheduled hopefully on the 5th of August, and then the last one for the year will be in November. There's a newsletter that will be due out in June, so that will have more information about the August teleconference. You may have seen this webinar today has been recorded, and so I'll be posting that on our website in the coming weeks, and also be emailing it out to anyone that is on the mailing list. If there's people that you know would have been interested and weren't able to attend today, just really encourage you to please share it with your networks. And again, I've just put up here our website and our email address in case any of you are not linked in with us already and you're really keen to. As I say, you can send me an email and I can join you onto our mailing list, or follow us on the website or social media as well. I hope you've really enjoyed today's teleconferences and our talks. I know I certainly have. And unless there's any final questions, I just want to thank you all for attending, and hope you have a really nice rest of your day.